Well, it's such a pleasure to be here with you. This is the first talk of our spring 2024 Global Health Politics Workshop series. Today, I'm very pleased to be here with Dr. Julie Lynch. Julie Lynch is from the University of Pennsylvania, Political Science Department. She's made lots of long-time contributions on the politics of public health, social policy, and we'll be talking today about health equity and political economy. I want to thank our sponsor, the Pardee Center for the Study of the Longer Range Future, for its continued support of this wonderful workshop. The bring scholars, practitioners alike together to have these important conversations. If you'll join me both online and here in welcoming Julie Lynch.
Okay, so this talk is sort of loosely based on an article that appeared in the Annual Review of Political Science last year. And so if you want sort of further detail about this talk, I would refer you to that article. So what I'm going to do today is basically three things. I want to talk about what I mean by political economy and political economy of health, because it's language that we're hearing a lot of these days. I think there are big calls for more of a political economy approach to public health, but it's not always clear exactly what that means. I'm going to talk a little bit about how I think a political economy approach can help us to understand health inequities and the sources of health inequities and what we can do about them. And then sort of open it up for some broader thoughts about what a political economy approach to health is good for, maybe some of the things that it's not so good for. All right, so what is political economy? Well, it turns out it really depends a lot on who you ask. So in political science, 20 years ago, people would say political economy, and we'd say, wait a minute, do you mean Berkeley political economy or APSA political economy? So APSA political economy was using economic methods, either formal modeling or fancy causally identified econometric techniques to model and understand politics. So that was APSA political economy. Then there came sort of a new wave of political economy in political science, which really meant thinking about politics as an interplay between different people and groups in the economy who we could conceptualize as interest maximizers. And we didn't have to know a whole lot else about them other than what we thought their interests were in order to understand how they would behave politically. And this had sort of, resonances with rational choice theory and with the economic formal modeling of the APSA political economy of 20 years ago. Then there was the Berkeley political economy. The Berkeley political economy was, and this was a sort of a tradition in comparative politics that came out of the political science department, but also the sociology department at Berkeley, and a number of other places as well, Wisconsin, another sort of hotbed of quote unquote Berkeley political economy, which really meant studying the political, social forces that drove economic and other policy choices. So it's the politics of the economy. Then finally, I think in public health and in much critical public health work, we've seen in recent years emerge what is really a critique of capitalism, and in particular neoliberal capitalism and its effects on health. And so another form of political economy, another understanding of what political economy means, particularly in the public health field, is this more critical approach to the health effects of capitalism. So 2020, this book with a chocolate cake on the cover comes out with the subtitle, The Political Economy of Health and Wealth. Well, so the big question is, what was I doing? What did I think political economy was? Well, I'm going to let you in on a little secret. Part of the reason I put political economy in the title is that, and a cake on the cover, is that political economy in political science is a very male-dominated field, and it's very quantitatively oriented. And I wanted to show that somebody who bakes cakes and who does a massive qualitative comparative historical study can also do political economy. So it was partly a polemical statement, but not entirely, because I think I do have sort of my own particular understanding of what political economy means, and in particular, the political economy of health. And that is understanding how the organization of politics, society, and the economy, which are all sort of mutually constitutive, right, influences the distribution of the upstream non-medical determinants of health. And so for me, that's kind of my baseline definition of what I mean by political economy. In the annual review piece, I talk about some of the mechanisms through which I think political economy impacts on health. And I cite a lot of literature, both from fields of public health and political science, and also some economists and sociologists. And I think it's important to kind of keep track of what those mechanisms are. It's not just sort of, we can't just say, oh, the politics of the economy. Yes, that definitely has an impact on health and health equity. I think we need to be really careful for reasons that I'll talk more about later. So I want to focus us on some key mechanisms. So one of them is the articulation and representation of interests in government and society. Who is organized? Who has a voice? How do they have a voice? How does that voice get translated into policy? These are all kind of core questions of political science. We need to look at the mechanisms of government action and government inaction. What are the things that the government does or does not do that have an impact on health? We need to look at how economic power in the economy, is translated into health outcomes. That's a part of political economy as well. And we can't forget that health and health equity aren't just things that happen to people. People have agency, right? And it's harder for people as individuals sometimes, but communities can respond and contest and can participate in reshaping the institutions that govern the society and the economy. And that too is a part of political economy. So when we think about political economy of health, I think we can sort of divide it into three chunks. One chunk is the policy determinants of health. Like, what are the things that the government does, either, as a reflection of interests in society or power in the economy or community action, but what are the things that government does that we know are sort of upstream drivers of public health? And there's a whole list of policies. Everything from how medical care systems are organized and regulated to climate, environmental policy, tech policy, which I didn't mention here, but which is also critical, particularly when it comes to data sharing, which governments need to do in order to address health inequalities, criminal legal system. So there's a whole range of policies, and people have actually done a lot of work looking at the health impacts and the impacts on health equity of a whole variety of policies. This is often work that's done by health economists or by people who are doing policy evaluations. It can also be done by political scientists or people, working in a sociological vein or in the School of Social Work or social policy. But this is the bread and butter, right? When we think about the politics of health, I think this is where we often go first. But I think there are two other levels that we really need to be thinking about. So one level is what we might call the political determinants of health, as opposed to the policy determinants of health. So this diagram here is tiny. You don't really need to see what's in it. It's illustrative. This is from Daniel Dawes' 2023 Hopkins University Press book, The Political Determinants of Health. And I put it up there basically just to remind you that this book exists. But also, Dawes has a very different way of thinking about what the political determinants of health are from how I think about it. there is, let 1,000 flowers bloom, right? Like, we need as much help as we can get here in terms of thinking about politics. The areas of politics that I sort of review and summarize in the annual review piece are a little different from the ones that Dawes points out. So I start with regime types, right? We have a big literature on the effects of democracy and authoritarianism on health and on health equity. We are moving into a period of kind of hybrid regimes here. It's not always clear what's a democracy and what is an authoritarian regime. And sometimes we might be worried that we might be moving from one into the other. And it would be really, really good to know if this great literature from the 1960s, which was sort of updated in the 1990s with the third wave of democratization, like, does that still hold? We need to know about this. Like, this is pretty important. But regime type is not the only kind of political factor out there. Legal institutions also matter. Things like constitutional rights to health or to health care. Things like suffrage, access to suffrage for women, for formerly imprisoned people, right? So voting rights, civil rights. These are all kind of legal institutions that I classify as among the political determinants of health. Then we can think about government partisanship and ideology. So you may have a democracy, but it probably matters who's running that democracy. Similarly, it probably matters who's running your autocracy too, right? Are they a left-leaning autocracy or a right-leaning autocracy? It matters for health and for health equity. Traditionally, the literature in this area has focused on sort of the left-right dimension in politics, but increasingly there's more focus on populism as kind of an axis that could be more or less independent of the left-right axis. And populism, at least from the limited data that we have so far, does seem to have specific impacts on health and health equity. So, for example, one of the things that you tend to see with populism is more restricted rights to medical care for women. You also tend to see loosened regulation of tobacco. So there are certain things that are kind of not really left-right issues per se, but that seem to bundle in with populist governments that are probably worth paying attention to. Political behavior. So one of the things that we know for sure is that people who are dead can't vote. I don't know if you noticed this, but recently a lot of extra people died. And those extra people weren't distributed evenly across society or across the political spectrum. The capacity of epidemics to reshape electorates is something that political scientists really haven't thought a lot about, but that I think is actually really incredibly important. There's been some work on this that shows how consequential it can be. There's also been work on sort of how HIV/AIDS has reshaped electorates in African countries, which is, I think, really illuminating and probably worth paying attention to. But political behavior and health are also related in other ways, somewhat more complicated. It seems that people who are disabled have more trouble voting, not surprisingly. It seems that people with mental illnesses are also less likely to participate in politics, and people who are ill generally, particularly if they are both poor and ill, are less likely to participate in politics. So political behavior matters, sort of above and beyond who people might be voting for and thus who ends up in office. Just the question of whether people participate at all in electoral politics, let alone in other forms of political engagement, is an important determinant of health. Finally, another political determinant of health that I think has really come to the fore during COVID is politicization and polarization, and how those can affect what we think of as very basic health behaviors, like, are you going to wear a mask? Or are you going to get your children vaccinated? When those things become bound up in other political commitments that are very strong, people's kind of what you might assume to be their self-interest in health can be overridden by prior political commitments. And this is something, again, it's very obvious in the US during the pandemic how masking and vaccination became sort of wrapped up in polarized partisanship. But we've also seen that with HIV/AIDS treatment in sub-Saharan Africa, for example. All right, so political determinants of health. It's not just policy. Policy definitely matters for health. We know that. Economists even can study that. But there's politics. So we might need people who understand politics, like political scientists and sociologists and communications experts and people like that who kind of get this part of it. And also geographers, because you do a little bit of everything. But it turns out it's not just politics either. So there's something else that seems to be behind this all, and the global public health community gets this. This is Dahlgren and Whitehead's rainbow model. This is one of the most widely recognized images in all of global public health, and it is a model that purports to explain where health inequalities come from. And the sort of purpley blue band of the rainbow on the outside tells us it's not just about individual lifestyle factors, it's not just about social and community networks, it's not just about where you live and work and what those conditions are like. There's some general socioeconomic, cultural, and environmental conditions out there yet to be named, right, that are doing some work here. So we've got the rainbow. We've also got rivers. We've got the pervasive upstream, downstream metaphor in public health, which is a very useful metaphor. I use it myself. And upstream, if we go all the way upstream, we get to things like political structures and institutional practices that assure fairness and opportunity for all. This one happens to come from the Illinois Department of Public Health. There are many other similar pictures of rivers out there, which have similar stuff all the way upstream. Ooh, then we get to the iceberg. So Fran Baum pioneered the iceberg in 2019. Love the iceberg. Fran's from Australia. What Australians know about icebergs, I do not know. But nevertheless, the iceberg metaphor has really taken off in global public health circles. The idea is what you see at the top of the iceberg is the disease. It's the health outcomes. And maybe these lifestyle risk factors, whether people are smoking or exercising or engaging in unprotected sex or using intravenous drugs, we can see that. What we can't see so well is what their sort of daily living conditions are just under the surface. And then all the way at the bottom in the murky depths, there are these economic and social structures. Local, regional, national, and global power and wealth distribution, fiscal policy, gender, and class. Ooh. The iceberg is we're going to hit that iceberg. So these are what we call the structural determinants of health, right? These things like structural racism and sexism, colonialism, dependency, for those of us old in the room, old enough to remember dependency theory, globalization, capitalism. I love this illustration by Ricardo Levins Morales. Capitalism is not healthy for children and other living things. I just think it's so great. Neoliberalism, right? These are all big structural factors that represent that outside layer of the rainbow, or the upstream in the river, the fundamental causes, the bottom of the iceberg. And this is where, the roots of health inequities are said to lie. Well, what makes determinants of health structural? Well, first of all, they structure other determinants, right? So they're the things that are farthest upstream. And you dump that stuff in the river, and it flows downstream, and it creates, let's say, inequalities in wealth. And then you go a little further downstream, and that gets to housing quality. And then you go a little further downstream, and that gets to illness, right? So the upstream structural determinants structure a lot of other stuff. They might be fundamental causes, to use Phelan and Lynch's language. They might be causes that are connected to outcomes via multiple pathways, so that when you knock out one pathway by introducing and disseminating a form of healthcare, for example, or sanitation, that fundamental causal power of something like wealth inequality or racism comes back and bites you through another avenue, right? So these structural determinants of health have this characteristic of very often of being fundamental causes. They also are about power, right? They're manifestations of power relations within societies, between the global north and the global south. But they're fundamentally about power. The other thing that's worth noticing about these structural determinants of health is they're aggregates. They're big. These are not one thing, right? You can't put your finger on something and say, that right there is capitalism, right? These are big, large-scale aggregates. And they're nebulous, thus the clouds. These happen to be cirrus clouds. Does anybody know what's special about cirrus clouds? No? All right. So the reason I wanted cirrus clouds on this slide is that cirrus clouds are the clouds that are highest up in the atmosphere, right? They're the ones that are highest up and hardest to touch, right? You can fly through cumulonimbus clouds, but you very rarely fly in an airplane through cirrus clouds. So they're nebulous, literally cloudy, like clouds. They're squishy. So these structural determinants of health are bad news from an analytic perspective, right? It is really hard to study something that you can't touch, that isn't one thing, that's super far upstream, and that is nebulous and squishy, right? This is the opposite of what we really want to be studying. If we are a health economist, we would like to see, a randomized controlled trial of a policy intervention that we can look at, and that is not this. So here's kind of the punchline. I think we can study this stuff. I think political science in particular, which has a lot of experience studying stuff like this, can help us think through how to analyze the effects of these really nebulous structural causes. So one approach to this is ontological, just figuring out what these things are. So if we talk about capitalism, we need to be very clear about what is capitalism, right? What is it made up of? What are its constituent parts? How do they relate to each other, right? Another way that we can kind of get some traction here is by thinking about our epistemology. How do we know about these things? How do we learn about their effects? And here I argue that really we want to be focusing on mechanisms rather than causal effects most of the time, right? Sometimes it's going to be easy to identify a causal effect. But with most of these big structural causes, we're really interested in looking for mechanisms. So we want to identify both mechanisms of action, the way things work, right? The pathways through which things have effects. And we also want to be able to identify mechanisms of reproduction. What are the forces that keep things in play for long enough to have an effect? And this is particularly important with something like health inequalities, which tend to have very long ecological periods. Finally, contextualizing is really important. These are big things. They're big, nebulous, they're way up high, they're like cirrus clouds, but they have an effect in a particular place, at a particular time, and on particular people, And so if we can contextualize the effects of these big nebulous forces, we are probably going to be both more accurate about what the effects are, but also more likely to be able to see it. So I want to talk you through an example, and that example is social democracy, something that is near and dear to scholars of health equity in the global north. So one of the most sort of prominent findings is that social democratic welfare states tend to have smaller inequalities in health, relative inequalities, than other kinds of welfare states. So conservative corporatist welfare states or liberal welfare states like in the US or the United Kingdom. Conservative corporatist welfare states are like those in Germany or France. But these social democratic welfare states, big, encompassing, tend to do better. So how do we understand that? Well, one thing we can do is we can chuck it in a regression and see what happens. And that has been pretty much the dominant mode of analysis, honestly, in terms of thinking about this well-known, well-established effect of social democracy on reducing the size of health inequalities. You chuck it in a regression. Well, as a political scientist, I have to say that just makes my head spin. This just does not work for me. So how do I want to deal with this? So I want to deal with this by thinking first at an ontological level, what is social democracy? What part of it do I think is doing the work? So social democracy could be a person, right? It could be Olof Palme here, who is the longtime head of the Swedish Social Democratic Party, who just happened to have certain beliefs and charisma and was a great leader, right? So it could be about him and his beliefs. It could be about social democratic ideology more generally. Well, if that's the case, like, what is it, right? Is it the egalitarianism? Is it the focus on full employment? Social democratic ideology has a lot of parts to it. So we want to think about what are all those different parts. Maybe it's not the ideology, maybe it's actually the party. Maybe it's the fact that there are really strong linkages between the social democratic parties and labor unions, particularly public sector labor unions. And you know what public sector labor unions do? They provide social care, they provide health care, they provide education, right? So maybe it's got something to do with like union party linkages. Maybe it's just down to the policies. Maybe it's just that social democrats, implement certain kinds of policies that just so happen to be good for reducing health inequalities. Or maybe there's something more sort of global than that. Maybe it's about social democratic regimes, which bundle ideology and parties and modes of governance and modes of labor relations. Like maybe it's something bigger that's not just the policies. So we really need to think hard, right? Like, I'm sorry, but you can't just chuck that into a regression. We can't do much. And yet they do. So, hang on. Yeah, there we go. So we need to be really careful about how we define social democracy and what we think is doing the work. But then we also need to think about the mechanisms. How is this working? So this is a graph from Tom Popinski's blog. Tom is a political scientist from April of 2020. And he's looking at the relationship, bivariate relationship between social democracy and COVID-19 caseloads. If you all were following the news, you might have noticed that a few months later, this graph would have looked really, really different, right? But, it's a bivariate relationship, which honestly, is maybe a little better than chucking it in a regression because at least you can see what's going on. But we still have no idea how we get from social democracy, whatever that is, to whatever specific health inequities we're interested in. Here it's COVID-19 caseloads, but it might be, relative inequalities in male disability-free life expectancy, right? Which are actually probably going to be really closely related to COVID-19 caseloads, right? But so we need to think hard. And here is where I think public health and medical experts really have the edge, right? They understand how inequality gets under the skin, rather, to produce health outcomes. So we really need to be working with them to understand kind of the end of that causal chain. How does whatever it is get under the skin? So we need to be looking at those mechanisms of action. We also need to be looking at mechanisms of reproduction. What keeps social democracy, whatever that is, in place for long enough to have its effect on health or on the determinants of health? And here, let me point out to you that these social democracies, some of them during this period are run by coalition governments of populists, conservatives, liberals, right? These are not social democracies in power. And so what on earth is the mechanism of reproduction that is keeping social democracy at work here to reduce COVID-19 caseloads in April of 2020, right? And then, of course, there's the question of contextualization, right? Temporal, right? What's the relationship between social democracy and COVID-19 case rates in 2020 versus 2022? It might look really different, but also spatial. So this here is a campaign button rather for the Social Democratic Party of the United States. Let's suppose that we elected a Social Democratic Party in the United States in November. What do you think are the chances that they would be able to massively reduce health inequalities, like now or even in 10 years from now? Right? There's a lot of other stuff going on here, right? You know, legacies of slavery, for example, don't go away just because you elect a Social Democratic Party. So thinking spatially, like, where is this big aggregate, nebulous, cloudy thing called social democracy? Where is it going to do its work? When is it going to do its work? And then also, on whom is it going to do its work? So again, to go back to Sweden and COVID, you know, if we have a social democratic policy in place, is it going to act the same way on native Swedes as it does on non-Swedish speaking immigrants? One of the things that we saw early in the COVID pandemic in Sweden was that messaging about social distancing was extremely effective. And this is why the Swedish government felt that they did not need to do lockdowns. It was extremely effective on the white Swedish speaking population. And it absolutely was not reaching the non-Swedish speaking immigrant population. And that was one of the reasons why you were seeing much higher case rates among non-native Swedes. So figuring out who this big nebulous phenomenon is going to act on is also an important form of contextualization. All right, this is my last slide. Why do we need a political economy of public health? I think there are two big reasons. One is very selfish and has nothing to do with most of you, and that is that I think it would be really good for political science, right? I think it would be really good for political science to collaborate and learn from public health folks. We like to talk a lot about having a policy impact. But the fact is, most political scientists don't know anybody who works in government, and public health people are working at the coalface all the time, right? They're doing implementation research. They are trying to communicate health messages via government agencies, right? So even in countries where academics have sort of more permeable boundaries with government than we do here in the United States, it's often very helpful for us to do our work, like having nothing to do with public health. It's often really helpful for us to just be in conversation with people who actually know policymakers. There are lots of other reasons, like public health people tend to understand mortality data. So we are less likely to do stupid things with mortality data, like assume that they're true. than we would be if we didn't talk to folks in public health. I think also, political science has like a problem with its soul at the moment. We are not interrogating power. We're really just not interested in that as a discipline. And for a discipline that's supposed to be all about understanding power, we've drifted really, really far away from that. And I think that engaging with public health kind of forces us to come back face to face with some of these big issues of power that are manifested in things like neoliberal capitalism and colonialism and its after effects, right? So I think it would be really good for political science if we had a political economy of public health. But probably most of you don't really care a lot about that, because why should you care about the problems of political science? Not your problems. I think there's a better reason, and that is because I think having a strong political economy of public health can really help promote structural competency among public health scholars and public health actors. So structural competency, I think Westbrook and Harvey in their recent paper have a really nice way of talking about what structural competency is. They talk about it as the trained ability to recognize and to respond to public health as an outcome of laws, policies, systems, and institutions, right? So it helps us to understand the big structural forces that are shaping public health, but probably more importantly, it helps us to respond to them, right? So if you're doing community level work, you really want to be able to communicate with the community and train people who might not otherwise be accustomed to viewing problems in a structural way, to have that structural competency, also to learn from people in the community who understand very well what are the structures that are causing problems for them, and to train ourselves in structural competency, right? So I think, looking at, you can't have structural competency if you don't understand structures. And then the other kind of final thing that I'll say is just that, I think public health sometimes has an unfortunate tendency to think about politics as kind of an aberration, right? That what really should be happening is evidence-based policy. Like that's even possible, right? I, as a political scientist, am here to tell you that there's no such thing as evidence-based policy, right? Politics is everywhere all the time. And so if you don't understand politics and you don't have the tools to analyze politics, then you're going to be in big trouble. So I think, much to its credit, public health as a field has been very attentive to the fact that politics is happening, but does not necessarily have all of the tools that it needs as a discipline to understand things like social democracy, and hence does unfortunate things like check-it-in regression equation. So I will stop there.